vaccine preventable cancer is which one? It is the carcinoma of cervix. What is the most commonly implicated HPV strain in case of carcinoma cervix? It is the HPV 16 and 18 commonly found. Even 31, 33, 35, 51 are the other important strains you need to remember, which are associated with cervical cancer. So typically, how is the HPV, human papilloma virus, is associated, doctor? If the HPV is not present, there is a checkpoint, just like a checkpost, G2 checkpoint, and a P53 protein will detect the mutation in the DNA, and the mutant DNA are not prevented from multiplying, and that is how the cervix remains normal and healthy. But in the presence of the HPV, this tumor suppressor gene P53 is inactivated, and there is no checkpoint on the G2 checkpoint, and that leads to development of the carcinogenesis. So G2 checkpoint, P53 and human papilloma virus are the important buzzwords which you need to basically remember. Now, what is the organism which is causing cervical carcinoma? Even 2014 DNB, HPV is what you have to basically remember. Now, what are the other predisposing factors for the carcinoma of the cervix, doctor? Typically, coitus before 18, multiple sexual partners, and delivery of the first baby before the age of 20, multiparity, poor personal hygiene, poor socio-economic status, and those who take combined oral contraceptive pills, they are at the risk of developing the endocervical cancer. Two types of cancer. Ectocervix, you have squamous cell carcinoma. Endocervix, you have adenocarcinoma. So that is predisposed by the combined oral contraceptive pills, and etc. etc. I'll leave the literature for you. Now, a case of carcinoma cervix who earlier received radiotherapy now relapses with a new lesion, and what is your line of management is the important question. Come on, shoot your answer, doctor. What do you think is the answer? Huh? You like to do? What do you like to do? Shoot a confident answer. Hysterectomy is an answer. Relapses with a new lesion, what is the next line of management? Unknown and others, what is their answer? Please punch your answer. Pelvic exenteration is considered to be the management of choice. Now, what percentage of cases do you have recurrence in case of cervical cancer who are being treated? 30% of cases. Whenever recurrence occurs, generally where does it occur? It occurs into pelvis, that is vagina, lateral pelvic wall and cervix are the classical locations. So what is the treatment protocol? If the recurrence occurs within 6 months after the primary therapy, then you basically call it as persistent cancer, and if it is occurring within 6 months, then you only call it as a recurrent disease. So that are the two important definitions. Suppose if it is a locally recurrent disease and the earlier treatment patient received was surgery, let us say. Primarily you have done a surgery and there is a local recurrence. Then what do you need to do? You need to basically treat them with a salvage radiation therapy. Similarly, if the primary treatment happened to be irradiation, initially you have irradiated the patient and there is a recurrence, then you need to consider surgical treatment. And if it is a distantly metastatic recurrent disease, recurrence happened but there are metastasis outside pelvis, then there is an indication for palliative chemotherapy. and whenever the recurrences happen with a previous treatment and they are centrally located, then pelvic excenteration is usually the procedure of choice for a centrally recurrent cervical cancer is what you have to emphatically remember. Okay, doctor? See, this is only a primer. Once more, you should be inspired to go back to open shop and have a chance to review. You review only treatment part of cervical cancer. Cervical cancer topic may human papilloma virus causes it, what will combined oral contraceptive pills cause it, everybody will know it, right? Before exam you need to revise, no? You should know which part of the topic deserves a revision. So which part commonly we do mistakes? Treatment part of cervical cancer. What are the protocols? Once you need to basically revise in cervical cancer. See, doctor, this is the area which you will be removing when you are doing pelvic excenteration. The ovaries, the bladder, the vagina is this matched area is the one which is basically removed at the time of excenteration. And this is a typical excentrated this thing, but not in case of carcinoma cervix. This was a case of prostate cancer. Actually, even in prostate cancer also, pelvic excenteration is the part of the treatment. Now, coming to carcinoma cervix, what is except about it? That is a vaccination. It can be taken along with other live vaccines at different sites. There is a bivalent vaccine, quadrivalent, and bivalent is more efficient and it is administered IM at 0, 2 and 6 months, and it requires further examinations after the administration of the vaccine. Now, doctor, trust me, tomorrow when you go and sit before DNB exam, one question inevitably comes from the vaccination. Because now there are national, international conferences. Everywhere you go, there is a talk on cervical cancer vaccines. So there is a reason it's a very, very hot topic for entrance exam and also worldwide. So to whom do you want to give? Between the age of 9 to 10, they are eligible for the vaccine. 11 to 12 is a recommended age group to receive the vaccine. 13 to 18, if they are not previously received, then they are the ones who are also eligible to receive. Similarly, 19 to 26 also you can give, but the effectiveness of the vaccine will be reduced in this age group. Why? Because assuming that the onset of sexual activity occurs very highly between 19 to 26 in any part of the world. So that is the reason any vaccine given before the exposure to HPV is more effective rather than giving it after the exposure. So that is the reason the best age would be 11 to 12, 13 to 18 if they didn't receive, 19 to 26 it is still effective if they have not been sexually exposed. And above 27, FDA didn't approve it, and men also it did not approve. So this is the typical recommendation which you need to basically remember. So this is the Gardasil vaccine, which typically contain 6, 11, 16, 18. They are the 4 strains which are there in the Gardasil quadrivalent vaccine is what you have to basically remember. Now let us talk about Pap smear. So what will Pap smear assess? When will you take the Pap smear? From where will you take the Pap smear? Is a very, very important question. Basically, Pap smear can assess the hormonal changes in the cervix. And upper lateral part of the vagina is the classical location, and it is whenever you do the pap smear, you will evenly spread it on the slide and then you will fix it. And it should be done before vaginal examination. And what is the age group where you want to do the pap smear? All women who have reached their 21 year, who are 3 years past coitarch, that is they already had sexual activity at 18 and they are 3 years from the onset of the sexual activity, or the age group 21 years is the age group, is the recommended age group. How frequently you want to do pap smear? Annually in case of the conventional pap smears, biannually if you are using liquid based cytology. And what is the age or what is the recommendation to stop continuing to do the pap smear? If the woman has reached an age of 30 years or older and she has got 3 consecutive negative smears, then instead of every year, you will do it once in every 3 years. If 3 consecutive samples are negative, that is considered to be the recommendation. And at what age you want to discontinue it? At the age of 70, if the patient had 3 pap smears negative in the preceding 10 years, or if the patient has already undergone total hysterectomy, they are the clinical scenarios where you want to stop doing the pap smear. So you need to be very sure on what are the recommendations of pap smear, which is the favorite question of the examiner. Now doctor, this is the most nagging question we are all bound to face in the entrance exam in DNB CET. What is the stage of the cervical cancer? So all stages, you need to close the eyes and have an imagination of the pelvis parametrial structures and must be able to get back the same imagination in the exam hall. That is a challenge. So what is your answer? 4A or 3B? Okay. What is 1A1? Invasion of less than 3, in depth and lateral spread less than 7, and it is confined to cervix. 1A2? More than 3, more than 7. More than 3 and less than 5, and lateral spread is still less than 7. Less than 7 or more than 7? Less than 7. Then 1B1. Clinically visible lesion greater than A2, 1A2, but less than 4 centimeters in greatest dimension. 1B2 is clinically visible lesion greater than 4 centimeters in the greatest dimension. 2A1, what does it mean? Upper 2/3 of the vagina without parametrial invasion and less than 4 centimeters in greatest dimension. And 2A2 is 4 centimeters in greatest dimension, 2B is with parametrial involvement, 3A is lower third of vagina with no extension to pelvic wall, and 3B is extension to the pelvic wall, or if there is a hydronephrosis or a non-functioning kidney is also 3B, and then if it extended beyond the true pelvis, then that will become 4. And you call it as 4A if it is to the adjacent organs, 4B if it is to the distant organs. So in the given case, where is the extension to? Lateral pelvic wall. That means it is still within the pelvis. That is the reason it becomes 3B, because it has extended to lateral pelvic wall is what you need to basically remember. Now doctor, this lost the power, please check. Now doctor, cervical cancer involving the inguinal lymph nodes belongs to which stage? Inguinal lymph nodes, it has extended beyond the pelvis. So that is the reason it should be stage 4B, because inguinal lymph nodes are not adjacent to pelvis. They are far from pelvis. Then doctor, stage 2B cervical cancer, what is the clinical management is a very, very important question. Stage 2B. Management of cervical cancer by stage. Favorite question in the entrance exam. Right? So, from December first week, every Monday and Wednesday, we'll have APPG. Last 25 years, topic wise classified and reviewed. 1995 to 2015. APPG question bank is unique in the country. If all entire country is on one side, our question bank is very unique kind of a thing. So definitely that will also help. Once more, issues will be same. Instead of 3B, they will give 3A. Add a little bit masala in that, they will catch where is the critical point in the topic. But you need to get that mastery. Suppose you studied the cervical cancer staging here, it's going to help you for JIPMER, PGI and all exams it is inevitable. Without knowing cervical cancer staging and mastery of that, you can't imagine or dream of crossing the Lakshman Rekha of competition, right? And remember, if you take the 2000 ranks or first 1000 ranks, once you finished mastery on certain X number of topics, you crossed the 1000 mark and came to 800. You finished some more topics, you crossed 800 and came to 600. Like that, certain X number of threshold you need to reach. Got my point? To be into that first top 100 ranks. If you didn't cross that mastery of that X number of threshold of topics, any number of entrances you write, you are still finding yourself beyond 1000 or 900 and you keep saying, oh, luck is not for me, etc. There is no luck factor, no magic here. Pure magic is exam hall mein, if you close your eyes, you should get the same dream of what is pelvic anatomy as that of what you are dreaming in the reading room. If both the dreams are same, you will get the seat, right? So now doctor, how will you manage cervical cancer based on the stage? So radiotherapy with combination chemotherapy is the management of stage 2B. But let us go, treatment of the cervical cancer by stage is the favorite question of the examiner. If it is stage 0, carcinoma in situ, to stage 1, then you can use laser or cryotherapy if it is endocervical in location. You can use the loop electrosurgical excision procedure, that is the LEEP. You can do cold knife cone biopsy if it is in ectocervix. Cervix has one ectocervix, endocervix. Then you can do total abdominal hysterectomy if already the woman finished her childbearing and is in the stage 0 or 1. That's the reason age is important. What is the age of the woman? And you can do conization or cryotherapy if the woman has only 0 to 1 stage cervical cancer, but still she wants to retain the uterus and she wants to bear few more children. So then you will do conization or cryotherapy. If it is stage 1A to 2A, then radical hysterectomy or radiation pelvic lymphadenectomy. Then hysterectomy or radiation, then you will do pelvic lymphadenectomy, para-aortic lymphadenectomy. Then 2B to 4B, you will be doing chemotherapy and also give radiation. So that is how by stage you classify. And in this given case, what is the stage given? 2B. That is the reason what should be therapy? Radio and chemo. is what you have to basically remember. Once more, examiner will ask the same questions repeatedly. Lateral pelvic wall, what is the stage? 3B. So what is the treatment of choice? Obviously, ideally, all of them can be done. Then stage 1B1, cervical cancer, 34 weeks pregnant female. What do you want to do? This is the real challenging clinical scenario in the clinical practice. Pregnant women getting discovered with cervical cancer, how do you want to manage? At the time of delivery of the baby, classical cesarean should be done, right? Not LSCS. Along with radical hysterectomy at the time of delivery is considered to be the management of choice. Now, what percentage of pregnancies, tomorrow when you are practicing as a gynecologist, obstetrician, what percentage of cases you will find pregnant women discovered to have cervical cancer? 3%. What is the average number of deliveries a MD DGO? Forget about DGO, MD will be doing, doctor. Assume about some 5 deliveries a day, 150 in a month, 1800 to 2000 in a year. That means how many cases 3% of 2000 means? 3% of 2000 means how many pregnancies with cervical cancer? Every 100, 3, every 1000, 30, every 2000 means 60 cases an average obstetrician comes across cervical cancer detected in a pregnant woman. Okay, so what are the typical symptoms? 1/3 of these patients will be asymptomatic unless you have a high index of suspicion. Then they can sometimes present with vaginal bleeding and discharge. Normally cervical cancer means post-coital vaginal bleeding or a post-menopausal bleeding. They are the important clinical presenting features that brings to your notice the presence of cervical cancer, right? So you will do screening. If you do screening, typically if more than 21-year-old patient, then you need to do cervical cytology. Just before we discussed about the recommendations when to do pap smear. Then if it is a low grade squamous carcinoma in situ like lesion, then patient age is more than 21 years, she should be managed like a non-pregnant patient. The only thing is, in case of a non-pregnant woman, suppose you have a low grade squamous carcinoma like lesion is there, then like cytology, after doing cytology, generally you will post for colposcopy. In a pregnant woman, when you do cytology and it is showing low grade squamous cytology, then you can't do colposcopy. Only thing is you need to postpone the colposcopy to about 6 months postpartum. That's the only difference. Then if it is a atypical squamous cells but of a high grade squamous intraepithelial lesion, then they require colposcopy, but they require basically colposcopy with biopsy. But the only difference between a non-pregnant and a pregnant woman is what? Typically you will do endocervical curettage. From ectocervix you can do a cone biopsy. But from the endocervical area, if there is adenocarcinoma suspected, you need to do endocervical curettage. That part of endocervical curettage you won't do in pregnant women. That is contraindicated. But still you will do colposcopy with the biopsy. When in a pregnant woman, if there is a high grade squamous intraepithelial lesion on cytology. If it is a low grade squamous intraepithelial lesion on cytology, then basically you will wait 6 weeks postpartum and then do it. So if it is a high grade squamous cytology, you have done colposcopy, and if it is negative, then what is the next thing you want to do? You ask her to come postpartum after about 6 weeks, and then you do the colposcopy once more. Can you do conization in a pregnant woman? Therapeutic conization is contraindicated in pregnant women, is what you need to basically remember, because it will lead to miscarriage. Because ultimately it is the cervix which is important for forming the lower segment, so you can't do conization on that. Then can you do diagnostic conization in a pregnant woman? You have to reserve it. You should not do in everybody. When do you want to do that? Whenever there is an invasive lesion suspected, but you cannot confirm it on simple biopsy, then colposcopy guided biopsy you have done in high grade squamous intraepithelial lesions. That is the place. Suppose if that biopsy is also not deciding whether it is cancer or not, you are not sure, then that is an indication for a diagnostic conization but not a therapeutic conization in case of a pregnant woman. Otherwise, you will always postpone conization postpartum rather than during the pregnancy is considered to be the important thing. Suppose you need to do conization. When will you do conization in a pregnant woman? Only diagnostic, not therapeutic. That too when colposcopic biopsy is not is leaving indeterminate results. And when will you do colposcopic biopsy? If there is a cytology showing high grade squamous intraepithelial lesions, then what is the best time to do that? For any surgical procedure, the best time is second trimester. Even cardiac lesion also, if you want to do mitral valve valvotomy in a pregnant woman who has got severe mitral stenosis, then the best time to do that is once more second trimester. Because first trimester you don't want to disturb the embryogenesis. Last trimester already the woman will be like a full moon day tidal waves of the ocean, Indian Ocean. If you go to vacation in Sri Lanka on a tidal wave, like that very high waves will be there, no? You will be finding yourself minuscule standing before Indian Ocean on a Sri Lankan beach on a full moon night. So, the plasma volume, everything will increase by the time final trimester. So that is not the right time. So second trimester. Then what are the complications which can occur because of these procedures? Hemorrhage and preterm labor can occur, and don't do CT but only do MRI in case of clinical staging is what you have to basically remember. Now, how do you treat cervical cancer is very important thing to basically review. Actually, I leave the literature for you. I mean, but since this being asked in DNB CET, definitely one more question is going to come on screening and treatment of cervical cancer in pregnancy. One thing is very simple. Radiotherapy cannot be given in pregnant women for whatever be the reason. Only chemotherapy. Then if it is a early stage disease, then you can do the cold knife conization if the patient has stage 1A1 cancer. If the stage is more than 1A2, then after the delivery you should plan for doing the treatment, not required to be delivered, treatment need not be delivered during pregnancy. If it is what? Stage 1A2. Then you can do platinum based chemotherapy typically in the second trimester. That is a time where you can start it and etc. etc. So I leave the literature for you to review on clinical management of a patient who is pregnant and found to have the cervical cancer. Okay, doctor. Now, in carcinoma cervix, surgery done, but you don't want to disturb the possibility of conception. That is minimal surgery. So minimal surgery is permitted till what stage of the carcinoma cervix without disturbing the fertility? Up to 1B1, you can still do minimally invasive surgery for carcinoma cervix without disturbing the fertility is what you have to basically remember. 45-year-old women who has got cervical dysplasia, what is the treatment of choice? It differs whether she finished her family size, India versus America. In India, for a village woman, for her to come for regular follow-up, leaving all her agricultural work, very difficult. So that is the reason they say please do the hysterectomy is what they will ask. So, but otherwise what is recommended is if it is only cervical dysplasia, then conization, diagnostic conization and follow-up is what is basically required, because it is still in a carcinoma in situ stage. So when you want to do diagnostic conization, indications are the favorite question of the examiner. Number one, if the colposcopy is unsatisfactory. So what is the meaning of satisfactory, unsatisfactory colposcopy? There is some story behind it. I need few more images to show you an example of unsatisfactory, and it is a squamocolumnar junction. Is it visible or not? At the time of colposcopy, will decide satisfactory and unsatisfactory. So if it is unsatisfactory, then you will do conization. If the lesion is extending into the cervical canal from the ectocervix, if the lesion is extending into the endocervical area, and you are not able to see it through the colposcope, indication for diagnostic conization, then you have done the endocervical curettage and you found the dysplasias, then that is a indication for diagnostic conization. And whenever between the cytology specimen, that is pepinicle or smear you have done, it is saying low grade lesion. Colposcopy guided biopsy you have done, there is a high grade lesion. Field umpire is saying wicket out. Far away umpire is saying not out. Then we will go to electronic umpire. So diagnostic conization is an electronic umpire where pap smear is showing low grade and colposcopy guided biopsy is showing high grade, then there is an indication. Similarly, if you are suspecting adenocarcinoma, if you are suspecting microinvasive carcinoma, they are all the important indications where diagnostic conization is done, is what you have to basically remember. Then Bethesda, HSIL includes what are the various stages. When will you call CIN1, CIN2 and all these things? They are all the typical terminology you will use for colposcopy guided biopsy findings. HSIL is basically what? Cytology finding. So what is the correlation between the two is what examiner is asking. So if you look at the carcinoma in situ, there are various degrees of carcinoma in situ. The lower video is coming, just see the projection. Yeah. You call it as mild dysplasia. When do you call? If it is only lower third of the epithelial lining. Moderate, when will you call? Lower 2/3. Severe dysplasia, when will you call? More than 2/3 of the epithelial thickness, you call it as the CIN3 is what need to be remembered. So if you look at the cytological classification of the Bethesda system, you have got CIN2, CIN3 and carcinoma in situ. These three are placed under the terminology called HSIL. HSIL means high grade squamous intraepithelial lesion on the Bethesda classification is what you have to basically remember. A 40-year-old with CIN3 has already had 2 children. So what is the best management? Just before, according to the stage how to treat we have reviewed. Come on, doctor. Finished family size. What do you want to do? Hysterectomy you want to do? Ideally, in Indian scenario. But the recommendations say punch biopsy. Now, let us see what is a typical recommendation. If the patient is old and family is complete, then simple hysterectomy. You will be doing LEEP or LITS if it is a young patient who is desirous of childbearing. That is the general protocol, is what you need to basically remember. So, whenever abnormal cervical cytology smear is there, you have done pap smear, abnormal cervical cytology smear is there, you look whether there is any visible lesion or no visible lesion, right? Cytology is showing abnormality. Then if it is a visible lesion, colposcopically visible, you do the biopsy. If it is positive, then look whether there is any invasive cancer, I mean what is the degree of invasion, and then initiate a definitive therapy. Suppose if it is not visible but abnormal cervical cytology is there, then you need to do a colposcopy and directed biopsy and endocervical curettage is considered to be the, that is the important indication, right? Suppose if there is no visible lesion, then on cervical cytology smear, what is the reporting you look into? Suppose if it is a squamous intraepithelial lesion or a atypical adeno-like lesion, these two, any of these three will basically mandate you to go for a colposcopy directed biopsy and endocervical curettage. Once more, based on the colposcopy and the directed biopsy and endocervical curettage, you see whether it is an ectocervical lesion or an endocervical lesion. If it is ectocervical lesion, look whether it is CIN1 or CIN2 or 3. If it is CIN1, do the expectant management. If it is CIN2 and 3, you try to do cryotherapy or laser or LEEP. And then in either case, you do a follow-up pap smear every 6 months is considered to be the recommendation. So, I leave the literature for you. So, if the starting point is an abnormal pap smear, how do you clinically approach after doing colposcopy and manage a case of cervical dysplasia? You must be very sure on the algorithm. Now doctor, a 38-year-old female, pap smear is showing high grade squamous intraepithelial lesion. What will be the best next step you want to do? Just before we discussed. Typically, we need to do colposcopy is what you have to be very sure about. Right, doctor? Once more, same issues will be there. Next to DNB, you are writing. When are you writing DNB? Next, last week of November, no? This Sunday, PGA is there. PGA Chandigarh exam is there, I believe. Am I right or wrong? Right? You are writing entrance, I am not writing. I am here only to discuss the paper. So, we will try to discuss the PGI Chandigarh 2015 November paper on Wednesday, next week Wednesday, and try to check what topics have come. Definitely one cervical cancer topic will be there. Was it there in the recent AIMS November? You attended AIMS November discussion, no? Cervical cancer question was not there? Not there? It will be there. It can be error of, we did not recall some 20-30 questions, maybe it is one among them. Now doctor, 30, we finish this question. Now, Ashkeem-Jaundice test is false positive in which scenario? First of all, what is the test? So, basically Ashkeem-Jaundice is a obsolete test, useless test, but asked in entrance exam still. It is a test to look at the increased HCG levels. Increased HCG can be found in hydatidiform mole, ectopic pregnancy, chorionic epithelioma asked 1991 DNB. 1991 is the MBBS batch I joined. After that it never asked, take it as an obsolete question. Now what is the draft choice? If you want to give chemotherapy in case of cervical cancer is a very important question. So basically it is the cisplatin based regimes is what you have to basically remember, and it includes platinum. Now comes the masala question of DNB CET, every entrance. Whenever you do brachytherapy of carcinoma cervix, what is the radiation that you will deliver at point A? So what is point A, what is point B, where are they located, and how much radiation you will deliver is the favorite issue. So what is your answer? 8? 8. Superb. So you have a point A and a point B. Point A, point B are in the same plane, but the distance will differ. It is 2 centimeter from the central point is point A, 2 plus 3, 5 centimeters away from the lateral pelvic wall. From the central area is basically point B, is what need to be remembered. So point A is in the paracervical triangle along the medial edge of the broad ligament, and here the uterine vessels cross the ureter, which is an anatomical landmark. Then point B is 5 centimeters from the midline and at the same level as that of the point A is what need to be remembered. And you will deliver about 7 to 8,000 centigrade point A and 6,000 centigrade the point B, and the whole idea is to not let the bladder get unnecessary radiation leading to radiation induced cystitis blah 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 is what need to be remembered. Who invented Pap smear? Come on. You thought Mr. Pap, obviously it should be Pepinicola only. There are too many Pepinicolas in the Italy. So, yeah. Like Srinivas is a common name. Every MBBS may without Srinivas, without a Venkat, without a Salim, without an Ali, there will be no batch. You tell me one batch which has got that. Every batch. So, who discovered Pap smear? Yes, doctor. It is the George Papanicolaou. He is Mr. George smiling at you, saying that if you don't know about George, you will not get seat to do MD in King George, right? So there are 2 King Georges. I think Vizag and Lucknow, both the medical colleges are called King George only. Okay. Actually, it is in 1950s where he discovered that. But once more, doctor, be very sure what is the sensitivity of Pap smear. CIN 2A and 3, it detects 47 to 62%. So Pap negative means it is not all negative. It may not be able to pick up. Specificity is between 60 to 95 is what you have to basically remember. Now, what is the most common histological variety of uterine cancer? So it is the adenocarcinoma, because endometrial cancer is all adeno. Endocervical cancer is also adeno, only ectocervical is squamous. That's the reason adeno is a predominant one. So that is the story of our topic number 1, which is carcinoma of cervix is what you need to basically remember.